Hello, welcome to the Midlands and East Region Red2Green webinar. This webinar is being delivered by Glen Burley, Chief Executive from South Warwickshire Foundation Trust and Wye Valley NHS Trust. Thank you, Glen, and I'll now hand over to you.
Thank you very much. I'm going to be talking about the experience that we've had, particularly at South Warwickshire, around improving flow in urgent and emergency care. And I'm going to be making references to some of the components of the National A&E Plan. When I do that, they'll appear in red on the screen. The plan itself is based on the guidance included in Safer, Faster, Better, which is hopefully a document that everyone is familiar with. And it contains all of the best practice advice that we have around improving urgent care in the NHS. There's two things I always say alongside the guide though. One is about it's really important to right-size solutions, and the second one is it's important that those solutions are owned by the clinical teams, particularly in the organisation, and implemented from the ground up. This is a slide I like to use a lot. It shows the bed occupancy in Warwick Hospital, which is the main acute site in South Warwickshire, by year of age. The red parts of the graph are urgent care admissions. And what it shows us is a typical DGH, which is predominantly full of frail older patients admitted as emergencies. And it's that group of patients that present the most significant challenge to all of us in improving flow. And indeed, in my own organisation, we had a number of challenges. We were at one stage investigated by our old regulator monitor because we were not delivering against the 4-hour standard. And over several years, we did this. We created extra bed capacity in order to improve flow. But all that extra bed capacity does is creates a warehouse-type solution. It doesn't improve flow. And we started to realise that by increasing beds, creating winter wards, or putting elective patients putting emergency patients into elective beds, you're creating risk as well as an inefficient system. So early on in our programme with the Health Foundation, we produced this data, which has now been replicated in an international quality and safety journal, showing how our mortality changed from the time at which we implemented flow from the time before, and from not hitting the A&E standard to when we did hit the A&E standard, we saw an improvement of 9 percentage points on our mortality. So why is that? Well, firstly, putting patients into outlier wards often means that we're using agency locum staff. They're often in the wrong subspecialty to ensure that their needs are being met. But also a crowded emergency department is not a great place for patients, and often it can be a situation where we're not able to start some of the important interventions, such as the sepsis bond, for example. So all of those things are contributing to poor quality. They're also contributing to an inefficient system. One of the other bits of evidence I often like to use is this one. That's a photograph of our main corridor at Warwick Hospital. It's on Christmas morning, and it's rather interesting across the NHS to notice that as we approach Christmas, suddenly our systems start to flow, and we generally have beds. Similar thing happened with the junior doctor's strike. Now, why is that? It's not just about demand. Whilst there were slight changes to demand on those days, those were generally patients who we wouldn't have admitted. What we see around Christmas and what we saw around the junior doctor's strike day were things like senior decision-making doctors doing what they should do on the ward, making decisions, making discharges happen. There was good planning, there always is leading up to Christmas, trying to get patients home, support from our community teams, a real focus on a deadline and really incentives for making it work. Why can't we have those same incentives and the same focus every single day? So what I'm going to talk to you about are 3 elements of flow. Looking at today's work today, looking at right sizing, and then looking at home first. I won't go into everything that you can do around flow, just a few examples from our own practice. So firstly, if we can start with doing today's work today. Early on in our work with the Health Foundation, a patient by the name of Gerry wrote to me with a complaint. The complaint said that the clinical teams were great and the staff were great. He had great confidence in them as individuals, but putting it all together, it wasn't very well coordinated. So what I did, rather than just sending him a standard complaint response, is brought him into the hospital and sat him down with those clinical teams, and they were obviously pleased to hear some of his positive feedback, but were really quite ashamed of a process which left a patient feeling that they were not getting value. So we process mapped his pathway, and as you can see from the data on this slide, we found that only 18% of his time in hospital was actually value added. The rest of the time he was waiting for things to happen, waiting for ward reviews, waiting for TTOs, waiting for test results. So this is very much aligned to the Red2Green Day principle around the safer bundle, making sure that on every single day something is happening to progress the patient's discharge. What we found when we looked further into Gerry's story is that one of the things that was not quite working well was around blood sciences. So we did a piece of work called Today's Bloods Today. We found that when our consultants went on to do ward rounds, on any one day only around 20% of the bloods had been taken that day. The others had been taken previously, and therefore it's quite hard to make sensible decisions. Often consultants were saying, well, let's do some more bloods and then let's decide what to do next. We found that this could be improved, so we process mapped. You can see that on the left-hand picture. One of the things that we realized is that the blood sciences team had implemented what they thought was a great solution to their cost improvement program. On the right, those pictures show some big blood gas analyzers. They reduced the cost per test, but big analyzers require big batches of work. So what we found is when the bloods were going to the department, they were batching them up and waiting to run the analyzers, reducing cost to them, but not cost to the system. So we changed that. The process mapping showed that we could get the phlebotomist slightly earlier to the ward. We could use the porters to take the bloods back to blood sciences and get them reported in small batches there and then. We also found some other interesting benefits in that our GP work often hits the department in the middle of the day. And when it did previously, there was a lot of work in the department. After the changes were implemented, they were able to do the GP work more quickly. So I received a rather unexpected letter of thanks from a GP. I didn't realise we'd actually done anything specifically around GPs, but it improved their flow as well. Those changes cost us absolutely nothing. They significantly improved clinical decision making and speeded up the process. So let's turn to the National A&E Plan. The element within that is about implementing safer, and on that slide there are lots of things that we should all be doing to ensure that we're making our wards flow. Written care plans, ensuring that there is a daily review, and certainly in the more intensive areas in the hospital, so emergency assessment units, for example, should be twice daily review. So that's one of the first elements that I wanted to talk about. The other element around the National A&E Plan is implementing internal professional standards. This is about ensuring that when a consultant refers to a colleague, there's an understood agreed response time, that when requests go for diagnostics, that there's an understood agreed response time, and those are negotiated locally and monitored and always delivered. There are some standards available from the Royal Colleges, but I think these things generally work if they're negotiated locally. So have you got those in your hospital? Are you monitoring them? And do you know when they're not being delivered? So moving on to right sizing. So right sizing is something that we do at South Warwickshire every 6 months or so regarding our wards. So ensuring that we have the right capacity. If things are too big, there's waste, and if things are too small, they can be rather embarrassing for all of us. So one of the areas that we look at is subspecialty ward bed numbers. You can't always get those perfectly right, but if you look at them every 6 months, you find the dynamics have changed. And if you're putting patients into the wrong subspecialty with the wrong teams, then you will impact on flow. So have a look at this every now and then and make the changes that you need to make in order to right size your system. It makes you more efficient. Another fine example of this is some work we did around point prevalence studies, where on a snapshot day you look at all the patients in all the beds in hospital and community and are discharged to assess capacity, and you determine whether they are in the right acuity level, or whether they could be treated in a less acute level. We generally find there are lots of patients in a level above where they actually could be treated. So this audit showed us that if we completely right-sized our system, we needed fewer acute beds, fewer community beds. Generally, it was showing us that more home care packages, more community capacity would make us more efficient. We grossed that up. In our system alone, that would have saved us £12 million if we could make that system work perfectly. So that takes me to the final element of flow, which is around home first. Previous slide showed that often the capacity is missing to deliver what is absolutely the right solution for patients, which is to be at home. There's lots of evidence on this. Dr. Ian Sturgis has produced some great slides in the past, which hopefully many of you will have seen, which show that the hospital setting is not the best setting for frail older people, particularly. 10 days in hospital, the equivalent of 10 years muscle wastage. So patients who are coming into hospital suddenly need care packages and suddenly can't live normal lives as a consequence of just being in the hospital bed for too long. For 45% of our over 85 admissions, they die within 1 year of hospital. So why do we waste so much of that time with them waiting for things to happen? We also cause half of our delayed transfers of care are caused by extended hospital stays, nothing to do with what was going on with that patient prior to admission. So we need to focus on ensuring that patients are in the right setting and that we speed up discharge. We often get distracted by delayed transfers of care. The evidence shows that if we focus on simple discharge, Pareto applies. There are many, many patients who simply need a small amount of things to be done in order to get them home, maybe with a bit of community team support. They're not the complex cases. So never forget that when we have discharge problems, much of this can be solved by the hospital. There are things that can be solved by more joined up systems. Using the stranded patient metric is, again, within the National A&E Plan. Looking at all patients in the hospital for longer than 6 days helps to identify where processes could be improved. So one of the other elements concentrates on those more complex discharge, and it's called discharge to assess. We've implemented that in South Warwickshire very successfully. I'm going to talk a little bit about the way that that works. As well as getting the capacity right, it is about some of the joined up working between health and social care and community and primary care. So in order for this to work, you do need to ensure that you've got good IT systems, that you're not marking each other's homework, that you've got care assessments that are agreed, that move between one part of the system and another. In our system in South Warwickshire, we have 3 pathways. Pathway 1, by far the biggest pathway, is those patients who can go home with support from community teams, from reablement services. Pathway 2 is where those patients are unable to return home immediately, a bit of further rehab in either a community hospital or a temporary residential home. It's really important that that is rehab, not just warehousing those patients in another part of the system. And then pathway 3, which is the one that often gets attention, is a smaller part of discharge to assess, but it's those complex patients who need nursing home care. And what we have done in South Warwickshire is the NHS has funded those for up to 6 weeks, moved the patients into a more appropriate setting, but again provided GP, therapist, nurse input to try and ensure that we do the assessments in the right setting, so no assessments in the acute hospital. We speed up the processes and we determine what their ongoing care package requirements are. Through implementing D2A, we've not only improved things for patients and delivered the A&E standard consistently, but we've also demonstrated that this is more efficient for everyone. So more patients are now going home without long-term care packages than they did before, which is great for them, but obviously a much more efficient solution. So another element within the National A&E Plan that links to discharge and a home first mentality is ambulatory emergency care. I won't go into a great lot of detail on this, but there are many, many patients who can be treated in an ambulatory setting. What we've done at Warwick Hospital is taken the view that every patient is ambulatory unless we prove otherwise. So we don't get them in their pajamas, we don't talk about them being admitted to hospital, we talk about them coming for assessment, and ideally with the frail older patients, getting them in the hospital early on in the day so that we've got a chance of getting an ambulatory solution and getting them home. So lots of other components to this. One other is about providing telephone advice to primary care, so not bringing the patients to hospital in the first place. There's a fantastic ambulatory emergency care network which I would encourage everyone to be part of, and I'd encourage everyone to look at the percentages of patients that you're treating in an ambulatory setting in your system. Another one is frailty. Again, National A&E Plan. This is reversing what many of us have put in place now, which is that we often let the subspecialties look at patients and then pass them on to the elderly care teams at the end. What we should do is have front door frailty assessment, ensure that it's multidisciplinary, that we have primary care, therapy staff in, ensuring that we identify patients with frailty syndromes with a comprehensive assessment, and that those teams work to get those patients home as quickly as possible. Again, at Warwick, this has really helped to reduce length of stay for those frail older patients. So one of the other added spin-offs of this for us has been improved patient satisfaction. So we've seen improvements in flow, and for our A&E department, we've actually seen them move from being middling in terms of the friends and family test to being one of the most positive in the top 10 nationally. We've also seen alongside that staff satisfaction has improved dramatically, and we're one of the best performing trusts in terms of the National Staff Survey. So there is a virtuous circle of ensuring that we focus on flow and safety, but it also drives efficiency. So the other added benefit for all of that, which as I've mentioned around staff satisfaction, is that it generally means that you have better recruitment and retention opportunities. So for us, our use of agency and locum is lower, staff are happier, and it's this virtuous circle of cost, quality and flow. I hope you've enjoyed this webinar, and I hope that you are able to implement much of the National A&E Plan in your own systems. Thank you very much for listening.